Hello and welcome to this educational seminar sponsored by Beyond Clean. And thank you for joining me in this CE presentation titled 10 Reasons Why, a case for monitoring low temperature and liquid chemical sterilants. Before I get started today, I'd like to take just a moment to thank my sponsor, ChemDAQ. I'd like to thank them very much for sponsoring this presentation and allowing me to do it. Very grateful. So as we get started, I'd like to discuss our objectives for today. We will discuss the importance of monitoring low temperature and liquid chemical sterilants. We will also describe the long-term exposure risks associated with low temperature and liquid chemical sterilants. We will explain the challenges related to low temperature sterilizers and equipment. And finally, we will explore the legal requirements related to low temperature and liquid chemical sterilants. So let's jump right into the topic. Number one on our list is that sterilant chemicals are highly toxic. They are designed to kill all microorganisms and spores. If they were not toxic, they would not be effective. It takes two. There are two main classes of chemical sterilants. Oxidizing agents, which are made up of hydrogen peroxide and parasitic acid. And both of these destroy the cell wall. The next is alkylating agents. This would be ethylene oxide. Ethylene oxide binds to the protein and DNA within the cell, preventing them to function properly. And I like to call these two posers because both of these agents pose a serious health risk to anyone who is exposed to them. So it's very important in your department to ensure that you have something in place to make sure that your staff know when they are in fact exposed. Next, the impact. We know that high concentrations and small leaks can have a significant impact on the health of your employees in the sterile processing department. Number two, sterilants pose serious health risks if you are exposed to them. So hospital-acquired infections, there's a huge focus. As you know or may not know, in this country, every year we have approximately 2 million hospital-acquired infections. Of these hospital-acquired infections, we have approximately 100,000 deaths. These deaths and these hospitalizations related to hospital-acquired infections result in an additional $45 billion in additional care for the healthcare costs in treating them. So there's, as you can imagine, a huge focus on hospital-acquired infections. As a matter of fact, there's been a huge focus since 1999 when the report To Err Is Human comes out, where the CMS talked about this very same issue with hospital-acquired infections, yet not much has changed. And when you think about this, this can be really troubling. It can be really bothersome. I know it bothers me personally. I don't know if you know or have heard of the author John Nance. John Nance wrote a book called Why Hospitals Should Fly. And John is the aviation expert for ABC News. And he was in the Air Force as a pilot. He flew C-141 Starlifters, and he got out of the military and became a civilian pilot, and then ultimately he became a judge, but he married a nurse. And as he listened to his wife, the nurse, tell stories about frustrations in the hospital, John started thinking, hey, you know, I think you've got an issue here. Much like was happening in the airline industry before we had our worst accident in aviation history. In the mid-'80s, the worst accident happened on an island in the South Pacific where one jumbo jet airliner basically drove through another, and John says that they had about 1,000 souls perish that day. And it happened because of a lack of communication, and it happened because at that time, John says that pilots were in a place where nobody could question them. They couldn't question their decisions. They couldn't question their authority. And he likens that to healthcare based on the discussions that he has had with his wife. And he says we have that very same issue because we have doctors who potentially could be in the same position where nobody can question their authority or their decisions, and they're making poor decisions. And so John wrote this book called Why Hospitals Should Fly. And in it, he talks about that crash. And he says those 1,000 souls were absolutely needlessly lost, but he compares that to the 100,000 souls that are perishing every year in the United States. And he says this is also inexcusable. But John puts it into a story that we can all relate to. He said if you take those 100,000 souls that are perishing every year and apply that to the airline industry, it would be like a jumbo jet airliner crashing to the earth 365 days a year and exploding on the runway. And I don't know about you, but I find this very interesting because if you think about aviation accidents in recent history, there's one in particular that I think of by Southwest Airlines, where the fuselage of the plane tore open and one soul was pulled out of the plane and perished on that flight. And if you think back to that, how many times did you see that story in the news over and over and over again, talking about the airline industry and flights and deaths and all of that? I can tell you that I saw it for weeks as the top story, and then for months as a story maybe a little deeper into the news, which is very frustrating to me. I'm frustrated for the family for losing the life of a family member, but I'm more frustrated for the 100,000 families every year that are losing loved ones, and we're doing nothing about it. We're not talking about it. How is this not the top story in the news every day? It's something that I just don't get, and it makes no sense to me. I hope that at some point we're going to take these hospital-acquired infections so seriously that it will be the top story in the news every day, and every resource and every dollar will be thrown at it until we can make this right. How does it make sense that we have this many people dying in the United States every year? Okay, I'm off my soapbox, so let's jump back into it. We've talked about the focus on hospital-acquired infections. So when you think in terms of that, there's a higher focus on hospital-acquired infections. Then we go to opposite of more, and we know the opposite of more is less. There is less emphasis placed on worker safety in hospitals today. And how is that? So y'all remember the song from John Cougar Mellencamp, a little ditty about Jack and Diane? Well, today we're going to talk about a little ditty about NIOSH and NORA. NIOSH is the National Institute for Occupational Health and Safety, and NORA is the National Occupational Research Agenda. And both of them say that healthcare workers are at an increased risk of many types of adverse health effects from these low temperature sterilants. For example, cancer, adverse reproductive outcomes, work-related asthma and dermatitis. And they also go on to say that overexposure to them is a big issue, and there's no such thing as a harmless chemical sterilant. As a matter of fact, if you're overexposed to glutaraldehyde or OPA and parasitic acid, they've both been linked to respiratory asthma, occupational asthma, and irritation, which brings us to that oxymoron that there truly is no such thing as a harmless chemical sterilant. And this brings us to our third reason, which is sterilizers and reprocessors can and do malfunction. When you think about these sterilizers, there can be a lot of assumptions about safety. Some facilities assume that an annual visit by an industrial hygienist or your quarterly visits by a service technician to check out the machine, that this makes them safe. The assumption is that their equipment is functioning properly. Nothing could be further from the truth. These sterilizers can and do break down and malfunction. It's very important that you're performing your daily and your weekly preventative maintenance on these machines to make sure that they continue operating the way that they should. And it's really interesting when you go on to think about it. I put down sound of the retreat. Continuous monitoring is a must. One customer that I visited had 4 new SteriAD sterilizers, and with continuous monitoring discovered that each of the units emitted between 25 and 40 parts per million of H2O2, or hydrogen peroxide, upon opening the door. So upon discovering that, this customer now sounds the retreat. I can almost hear the bugle blowing where they sound the retreat, they open the door and they run out of the room and they let the room aerate until they believe that it is safe. They return to the room to take the load out of the sterilizer. Continuous monitoring is a must. This is a gaseous situation. ChemDAQ has installed gas monitoring at several facilities that resulted in the system alarming immediately upon commission. In one case, the exhaust fan supporting the ETO sterilizer had been knocked out by a thunderstorm, and no one knew it because the exhaust fan is up on the roof. In another case, an exhaust duct between the sterilizer and the abator was the culprit. Both were leaking. They didn't know it until they had continuous monitoring. This leads me to a story about Leaky Pete. And if you remember Leaky Pete, there are many cases of customers discovering leaks. Sterilizer manufacturers go to great lengths to make them as safe as possible. Still, releases of gas occur. It is vital that hospitals utilize continuous monitoring to keep employees safe. Monitoring your area once a year is not adequate. Number 4, smell is an unreliable method of detection. To smell or not to smell. Our sense of smell was developed to tell us what is good to eat and what we should stay away from. Many folks believe that it should protect us from harmful chemicals as well. Unfortunately, smell is not a good method for determining if a sterilant vapor is present at a safe concentration or not. As a matter of fact, sterilants like ETO and H2O2, or hydrogen peroxide, have no smell until they're far beyond safe levels. For example, the odor threshold for ETO is around 430 parts per million. This is compared to the OSHA Permissible Exposure Limit, or PEL, P-E-L, of 1 part per minute, calculated as an 8-hour time-weighted average, or TWA. Hydrogen peroxide also has no smell, and people typically perceive it from irritation in the eyes and respiratory system. That's just pungent. Odor threshold ranges. So when you think about something being pungent, it smells awful. Some liquid chemical sterilants, such as peracetic acid and ozone, have a pungent odor. It's still very difficult to determine if the concentration level is safe or not. There's also great variability in the odor threshold from one person to another. And what about allergies? I know I can tell you down here in Texas every year, particularly this time of the year, we have a lot of pollen in the air. I have 4 pecan trees in my yard, and you would not believe the amount of pollen that falls out of these trees. So half the time I'm sneezing or sniffling or I'm stuffed up, and I know that my staff are exactly the same way. So how can you depend on your nose to smell a gas leak if you're dealing with allergies? It's just not going to work, right? Next, I want to talk about an old Top Gun song, if y'all remember this, Right Into the Danger Zone, where we're going to talk about right into the vapor zone. Many gases and vapors are subject to olfactory fatigue, meaning our nose gets tired. Prolonged exposure to gas vapors reduces the sense of smell over time. Come on now. We know how crazy it is in sterile processing, so coupling this busyness and hecticness that goes on in our department with allergies and running around, our noses are going to get tired and we're just going to get used to these smells. so not so calibrated. Noses aren't good gauges for safe levels. The bottom line is that our noses have not been calibrated to determine whether a liquid chemical sterilant is below or above the parts per million threshold for safe practice. The only way that we can accurately determine the safe level of liquid and chemical sterilants is through the use of continuous monitoring devices. And I want to take a short break here and ask you a question. I would like to know, how many of you listening in today have continuous monitoring devices in your facility? Likewise, how many of you do not have continuous monitoring devices in your departments for liquid and chemical sterilants? Why don't you take some time and go down to the question and answer bar and just type in there, yes, we have it in our facility, or no, we do not. I'd love to see the numbers of the people listening in, but I can tell you this. A majority of the facilities that I visit around the country when I do assessments do not have area monitoring. They're relying on personal badge monitoring, and they have no way of knowing if they have a big leak in the department. This brings us to number 5 when we think of health and safety. Employers have a legal duty to provide safe work environments. In doing so, they need to follow the OSHA Act of 1970. This created a legal duty for employers to provide a safe working environment and a legal duty for employees to follow all workplace safety standards. And before I jump into this, when we talk about safety standards, leaders, how many times have you gone into your decontamination area and your staff have not been wearing the appropriate PPE? That would fall under this act. It would also fall under the OSHA bloodborne pathogen rule that we know is in 29 CFR 1910. But as we get back into this OSHA Act says that each employer shall furnish a work environment free from recognized hazards that can or are likely to cause death or serious physical harm to the employees. They must also comply with occupational safety and health standards promulgated under this Act. And each employee shall comply with the occupational safety and health standard and all rules, regulations, and orders pursuant to this Act, which are applicable to his own actions and conduct. So we as employees are being held accountable as well. So it's very important that we have the appropriate tools to perform our job and to stay safe while performing our job. So we think about clauses, and clause, I'm not talking about Santa. We're going to talk about the General Duty Clause, 29 CFR. It is a catch-all regulation that allows OSHA to prosecute employers with dangerous work areas, even when there is no specific regulation. 29 CFR 1910.1000 provides maximum PELs or permissible exposure limits for specific compounds. For example, hydrogen peroxide is calculated at 1 part per million per 8-hour time weighted average. In 29 CFR 1910.1200, it says that it's intended to inform employees about the hazardous chemicals that they are using. HAZCOM, which refers to the signs that we see in the departments, involve labeling of chemicals, the use of safety data sheets, and especially training. HAZCOM has been revised to improve worker understanding of risk and conformity with the global harmonization system. Also, 29 CFR 1910.1047, the air contaminant standards, which cover certain chemicals which are carcinogens. This would be ethylene oxide, for example. Ethylene oxide has a PEL of 5 parts per million at a 15-minute time-weighted average, and a 1 part per million at an 8-hour time-weighted average. So when you're thinking about this, it's an all for one and one for all. Hospitals, still mills, water treatment plants, etc., they all are subject to this CFR. The air contaminant standard and the ETO standard are performance standards that set goals that leave the means to achieve the goal up to the employer. It gives the employer the flexibility to select the means best suited to their application, meaning that they can select it, but they have to select it. They can't not select it. And to me, that's kind of alerting. Another example is the ethylene oxide standard, ETO. It calls for alerting employees where there is a possibility of an employee exposure due to ETO in an emergency and should alert them promptly. Affected employees should be immediately evacuated from the affected area. This is really a big deal. It makes me think of a time not so long ago when I was managing a department. We had an area monitoring system, and in my sterile processing department that was located in the basement, we had an ethylene oxide sterilizer, and we in fact had a leak. And my alarm started going off, so my staff called me. We evacuated the department. We promptly called the fire department, who came in their hazmat suits with their chemical testers. They found the leak for us. But at the end of the day, that monitoring system literally saved the lives of my staff. I had staff who, had we not known that there was a leak, that would have been breathing in a known carcinogen for who knows how long until it was discovered. So thank goodness we had that system in our department. This brings us to number 6. Occupational exposure limits already exist. So I'd like to ask you another question here. At what concentration is a toxic gas toxic? Well, the ACGIH, the American Conference of Government Industrial Hygienists, developed threshold limit values in the 1940s, PLVs, and they regularly updated them as data became available. There are now more than 700 chemicals and physical agents listed. The ACGIH is a private organization, so their threshold limit values are not law, though the laws of some countries actually reference them directly. Moving from them, we can talk about OSHA. We've talked about them a little bit, but the Occupational Safety and Health Administration can prosecute in the U.S. under the General Duty Clause using the relevant TBLs as a threshold to indicate whether a work created in 1970 and charged with promulgating these PELs, personal exposure limits. The first PELs were created in 1971 and were taken from the Act of 1968, ACGIH TLVs, since they had already been adopted as federal standard in 1969 as a part of the Walsh-Healy Act revision, which then brings us to PELs, PEL, Permissible Exposure Limit, the legal standard for the maximum exposure that an employee may receive. For chemicals with no PEL, employers should reference the ACGIH TBLs and the NIOSH recommended exposure limits, as well as the Cal-OSHA PEL limits. OSHA recommends following these other exposure limits if they are at lower concentration levels. And finally, oh my, I don't know about you, if the TBLs and the TLVs and the PELs and the OSHAs and the ACGIH TBLs hasn't gotten you confused, I don't know what would. This information can flat out be overwhelming for SPD leaders, so it's vitally important that we take the time to understand what they are talking about. Many of the compounds that were introduced in the 1970s were introduced as sterilants and high-level disinfectants, and they have OSHA PELs or NIOSH RELs, but this does not mean that they're safe. For example, parasitic acid has a TDL of 0.4 parts per million calculated as a 15-minute TWA. OPA has no exposure limit, but undoubtedly is toxic. For those compounds without an OSHA PEL, the employer should follow the best standard available from a reputable organization such as NIOSH or ACGIH, the American Conference of Government Industrial Hygienists. If no other standards are available, the employer should seek guidance from other sources, such as the safety data sheet, ask the chemical manufacturer about their recommended exposure levels, or consult other safety publications or professionals. This brings us to number 7. OSHA requires safety measures for employees. When you think about these safety measures, OSHA in their education says employee training shall at least include methods of observation to be used to detect the presence or release of hazardous chemicals in the work area, such as monitoring conducted by an employer, continuous monitoring devices, visual appearance or odor of hazardous chemical when it is being released, etc. The physical health, simple asphyxiation, combustible dust, and pyrophoric gas hazards, as well as hazards not otherwise classified chemicals in the work area. The measures that employees can take to protect themselves from hazards include specific procedures the employer has implemented to protect the employees from exposure to hazardous chemicals, such as appropriate work practices, emergencies, and personal protective equipment to be used. And here you can reference CRF 1910.1200. Automatic, it's meant to detect the presence of sterilant gas automatically. So sterilant chemicals used to sterilize temperature-sensitive medical devices are imperceptible to human senses until at concentrations well above the dangerous level. And these are often not quantifiable by smell. So is it too late? It's too late. Many facilities believe that they're protecting their people by means of exposure badges. This is not the case. Badges are worn for 8 hours and then sent to a laboratory for analysis. When the results are in, the employees will learn if they've been exposed to a sterilant gas or not. This is too late. Badges provide a false sense of security. Badges provide no warning of current exposure, and in the event of a major leak, the badge would only provide a record of how large the wearer's exposure was. And I take this back to the time when my department had a leak. If I had only been badge monitoring, my staff would have received significant doses of ethylene oxide, a carcinogen. We would not have known it. We would have sent the badges off, and we would have got the report back that they were exposed to very high levels, but we didn't know when. And we didn't know how many people from the time of the exposure until the time the badges came back had continued to be exposed. So this is a real significant issue. I'd like to talk to leaders here right now and say that if you do not have continuous monitoring in your department, start talking to your administrators to get it stat. You need to have this in your department to be keeping your staff safe. So when you think about this, proactive versus reactive, badges provide a reactivity safety net for the individuals wearing them. The only way, let me say that again, the only way to proactively protect staff is by continuous monitoring. And this brings us to number 8, mitigate the risk of litigation. As everybody knows here in the United States, we are definitely a litigious society. We have lawyer billboards everywhere. You can sue somebody for anything. In the OSHA Act of 1970, OSHA is tasked with enforcing occupational safety laws. It says that they may conduct random inspections of workplaces. It can act as a response to an employee complaint concerning work practices, or it can visit following a reportable incident. And when they come in, the numbers are in. Basically, OSHA has visited 1,714 of the 5,724 general medical and surgical hospitals. Thus, on average, each hospital can be inspected every 33 years. Does anything sound wrong with that to you? Each hospital can be inspected every 33 years. In practice, some hospitals have been inspected more than this due to employee complaints, which then takes us to cost. If OSHA comes in and discovers non-compliance during a visit, they may issue warnings or fines depending on the magnitude of the infraction. Fines for each violation cannot be more than $70,000 for each violation, but not less than $5,000. OSHA penalties are increased based on inflation. So listen to these numbers. The penalties for a serious violation are $13,494 per violation. And remember, they can go all the way up to $70,000, but the penalty for a serious violation, something that is impacting one of our employees' lives, is $13,500, give or take a few dollars. In 2020, it will increase to $13,947. So we're going to see a $3 increase for willful violations. I don't know about y'all, but this really bothers me. So employers want to reduce the risk of employee injury. Employees should also take steps to reduce the risk. This leads me to reducing it, reducing the risk of employee injury. So employers should take the steps to reduce the risk of employee injury by reviewing the workplace for safety and compliance, developing a written safety plan and policies and procedures around 29 CFR 1910.3939 and the HAZCOM plan 1910.1200. And they should be ensuring that the necessary equipment is available and employees have been trained how to use it. And they should also be performing regular inspections. This is vitally important. So we want to make sure that we're mitigating the risk, but we want to make sure also that they have the equipment to keep them safe and to perform their jobs safely and more efficiently. And with that, we should be inspecting the department to make sure that they have the equipment and that they're actually wearing the equipment. I brought that up earlier when I said, when I asked the question, have any of you ever gone into the decontamination area and your staff aren't wearing the appropriate PPE? They're putting themselves at risk when they do this, and they're putting their families at risk when they do this. So it's vitally important that as an employer, you make sure that they are wearing the PPE that you have provided them. And this takes us to number 9. All of these issues leading up to this can increase lost time from work. So as employers, we need to figure out a way to reduce lost time. And there's no better way to say it than the little black slate plaque on the slide that says, remember, time lost cannot be regained. So when you think about lost, exposure to chemical sterilants and high-level disinfectants can result in lost workdays, high turnover costs, and higher worker compensation rates. According to the Bureau of Labor Statistics, in 2018, there were 512,000 injuries and 32,700 illnesses in the healthcare and social assistance industry, or 310 per 10,000 full-time workers. The BLS, the Bureau of Labor Statistics, commented that healthcare and social assistance workers had the highest number of injuries and illness, 1 in 5 cases reported. The numbers have not changed over the last decade. The injury and illness rate of healthcare workers was 238 cases per 10,000. That's almost 2.5 times the rate for all of our privacy industry that's out there. This is unacceptable. Workers who have dedicated their lives to caring for our loved ones when they are sick are the very same workers who face the highest risk for a work-related injury or illness. How does that make sense? If you look at it right now, during this pandemic, we have healthcare professionals that are struggling to get the PPE that they need to do their job. They're having to rewear PPE all day long. They're having to reprocess or disinfect PPE to wear it. How did we get to this place in the United States of America where we can't supply the PPE needed to our employees? There are so many stories out there. There's stories of a group of nurses who refused to go into a room of a COVID positive patient because they had no PPE. They were all placed on administrative leave. So they had to decide, do I go in there, make myself sick, take this disease home, make my family sick, and potentially kill my family because my healthcare facility can't provide the tools that I need to do my job correctly? How did we get to this place? What about the doctor in Washington State who worked in the ER that complained about not having personal protective equipment? He was fired. Come on, folks. This makes no sense. What about destruction? These injuries can end up destroying a family's emotional and financial security very rapidly. These same injuries take an enormous toll on our nation's economy, and this toll is intolerable. Safety means safety. Employee safety is not contradictory to patient safety. The Joint Commission states that according to hospital and health networks, more than 250 healthcare workers are injured every year at work, and more than $20 billion is spent each year on worker compensation costs. The primary goal of healthcare is patient safety, folks. But patient care cannot be absent of safety to the healthcare workers on the front lines. How much sense does this make? We have got to be taking care of these healthcare professionals who have stepped into an industry and said, I will go to work every day and I will fight for your family, but just give me the stuff that I need to do my job. This brings us to number 10. Show your employees their value. Number 1, the greatest challenge equals employee turnover. In sterile processing, one of our biggest challenges is employee turnover. When we lose an employee, it is a catastrophe. The training that goes into training a new employee, the time, the resources, the energy is incredible. As a matter of fact, they say when you talk about turnover, that it results in approximately $40,000 in additional training costs per employee. $40,000 in additional training costs per employee. This leads to failure. It has an enormous effect on employee satisfaction, surgeon satisfaction, and overall quality. If you're constantly taking an employee after they've left, hiring one, and then taking another employee out of your daily routine to train that employee, now you've got 2 employees impacted and a third that left. So it has a huge, huge impact on your department. And finally, value. If an employee feels valued, then they will perform better and are much less likely to change jobs. Did you know that feeling appreciated is a strong, strong motivator? An employer who fails to train their employees about how to work safely, fails to provide the engineering controls, continuous monitors, and other measures to keep their workforce safe will not enjoy the respect and appreciation of their workforce. This is simple, folks. Our staff have got to feel loved and appreciated, or they're not going to work and they're going to leave and they're going to go somewhere else. So we have to be doing everything that we can as leaders to make our workplaces safe, to make it a place where people want to come to work and they want to come in and they know that they're valued and they're going to have the tools that they need to do their job. And this brings me back to our initial slide that talked about what we are going to talk about today. We talked about the 10 rules for monitoring low temperature sterilants and chemicals. So number 1, we know that these sterilants are highly toxic. Number 2, these sterilants pose serious health risks if one is exposed to them. Number 3, sterilizers and reprocessors can and will and do malfunction. So we need to make sure that we're staying on top of the preventative maintenance. Number 4, smell is an unreliable method of detection. Number 5, employers have a legal duty to provide safe work environments. Number 6, occupational exposure limits already exist. So why are we not enforcing them? Why is ethylene oxide enforced, but hydrogen peroxide not, when they both have the exact same part per million exposure limit set at 1 part per million? Number 7, OSHA requires safety measures for employees. Listen up, employers. OSHA requires safety measures for employees. Number 8, we want to mitigate the risk of litigation. Number 9, we want to reduce lost time from work. And finally, number 10, show your employees their value. Let them know how valuable they are, and they will come back day after day and do a job that you can't even imagine for you every day, because they love you, they respect you, they want to work for you because they know that you love and respect them, and you're going to take care of them in the workplace. Folks, that's all I have for today. I hope you've enjoyed this presentation. Again, I would like to thank my sponsor, ChemDAQ, and I'd like to ask if any of you have questions at this time.
All right, Bob, thank you for getting everyone fired up about chemical monitoring this morning. We have quite a few great questions that have come through from all of our participating audience members. And we actually expected there to be a lot of questions about this topic. So we do have a team of people here ready to field these questions. We have Dr. Richard Warburton and Matthew Chichester from ChemDAQ, and we also have Bob Mars, obviously, from Beyond Clean. So let's get right into it. The first question, how close would an employee need to be exposed to hydrogen peroxide fumes above the 1 part per million in 8 hours? In a large hospital, STERRAD cycle counts rarely reach 10 cycles per machine, and they're usually in a large room. Richard, can I throw that question over to you?
Yeah, I think it's a hard question to answer because it would depend upon on the status of the machine. If the machine is working well, then the sterilizers, like most modern sterilizers, are very reliable, very well engineered, and rarely leak. But of course, like any machine, sometimes things can go wrong. You get wear and tear, human error, and of course, just mechanical failures. They can occur. And so the answer to the question depends upon how much hydrogen peroxide gets out, and what the size of the room, and the air exchanges, and so forth. So it's a difficult question to put a number on.
Okay. Next question: has OSHA, CDC, or any other agency reported overexposure health effect from any hydrogen peroxide process?
Richard, go ahead.
Okay. Not recently, there haven't been. In the past, there have been quite a lot of reports in the FDA MORE database about about exposures to people being exposed to hydrogen peroxide and the effects thereof. And even those, of course, are just anecdotal. They're not they're not reports from the agency. There have been some recalls of hydrogen peroxide sterilizers in the past because of malfunctions and because of occupational exposure. But none recently.
Yeah, and to Richard's point, I don't know if everyone's familiar with it or not, but there is the MAUDE database through the FDA, and that's the Manufacturer and User Facility Device Experience. So people can go on there and mention things that have happened or issues they've had.
All right, next question. Our hospital, and Matt, I'm going to send this one over to you. Our hospital uses ethylene oxide and hydrogen peroxide. Can you detect both?
Yeah, definitely. There's sensors out there for all sorts of chemicals. Typically, those sensors aren't going to be able to detect multiple chemicals at the same time, but there are sensors for each different chemical if you need them. Peracetic acid is another popular one that that is used in hospitals and in many different locations in the hospital, and should be detected and monitored for. And a lot of these systems that are out there and available to the hospitals, you can have sensors for different gases that link back to the same system. So you can know what's going on with your ethylene oxide, what's going on with your hydrogen peroxide, and your parasitic acid, all from the same view.
Right. Richard, I have another question that I'm going to direct to you. When you say that sterilizers may leak, and I know that Bob mentioned this during his presentation, when you say this, what exactly do you mean? They'll leak during the sterilization cycle? When does that leak typically occur?
There were
if it
different.
does occur.
Yeah, most sterilizers, as I said earlier, are very reliable and normally they're designed not to leak, but things can go wrong, and there are different places they can go wrong. For example, that there could be a leak in the exhaust system, so that the hydrogen peroxide is released before it reaches the catalytic converter, or the catalytic converter can fail, so some of the hydrogen peroxide gets through and is then exhausted into the air. Or you can have hydrogen peroxide that remains, some hydrogen peroxide vapor that will remain in the chamber. So when the door is opened, that vapor will come out. So there are different stages in the cycle where you could potentially get hydrogen peroxide leaks.
Okay, and a follow-up question for you, Richard. If at an end of a STERAD cycle, the hydrogen peroxide is broken down to water and oxygen, why would monitoring be needed? If a leak occurs from the machines, they're sensitive enough to abort the load, and all those fail-safes are in place, correct?
Yes. I think one of the things to remember here is that during a sterilizer cycle, the hydrogen peroxide concentration is high enough to kill everything. It's a sterilizer. It's designed to kill everything, and those concentrations are orders of magnitude higher than what we are concerned about in terms of occupational safety. So if you had a small leak of hydrogen peroxide out of the system, then it really doesn't make much difference in terms of the overall hydrogen peroxide in the chamber. Also, suppose you had a leak that it was passing out through the catalytic converter, that would never show up in any of the fail safes. If you have say a few ppm left in the chamber at the end of the cycle, you're not going to see that by the pressure sensors used to check for leaks in the system. So there are many ways that a sterilizer can leak that won't be picked up by the many fail safes that the manufacturers put into the sterilizers.
Thank you for that answer, Richard. Matt, I'm going to throw one over to you. Education is key. Staff sometimes have an allergic reaction, ranging from slight burning sensations to sneezing. Is it true that they might not even know that hydrogen peroxide vapor might be the cause of those reactions?
Yeah, I mean, I saw that question come in, and I think that's just genius on their part to even realize that. And that's really what we're saying, and I think that's what obviously Beyond Clean is saying. It's all about education. You want to know your environment. We're not saying that people are constantly in all situations around chemicals. We're not saying that machines are leaking all the time. We're saying that you need to understand your environment. So if there is chemicals around or there is a major leak, you're aware of it. Because people are working hard, they don't like to complain much, right? So they might have a sneeze or a burn or an itch or an eye irritation, and they say, oh, it's my allergies, or oh, my kid was sick, or so I probably got something from them, and they don't even realize that they are being exposed to this stuff. So yeah, great point. I mean, that's why you monitor. You have to educate and let people know what the possible effects are and what to look for. So yeah, that's great.
All right, and another question that came through, Matt, I'll throw this one to you. Our department uses both Steriles and VPROs. Are there any issues associated with two different types of hydrogen peroxide sterilizers in the same space?
No, I mean, again, you know, there's several different models out there for you know, ethylene oxide and for hydrogen peroxide and for peracetic acid, you know, different manufacturers. Some we would say probably have less off-gassing issues or what, you know, we use the word leak. It's not always like you think about, like leaking while the cycle is going on. Sometimes what we're saying by leak is, again, after the cycle is over, all the hydrogen peroxide, for instance, has not been broken down. So when you open the door to the sterilizer, it's leaking out is what we're saying, right? It's coming right out of the sterilizer. So imagine a microwave oven that's on fire and you open it, and that smoke's going to come out and up, right? Well, that's hot hydrogen peroxide, heated hydrogen peroxide coming out. It's going to come out and up right towards your breathing zone. So, you know, different manufacturers, different machines, you know, might work a little bit differently. But at the end of the day, if they're using these chemicals, they can be monitored.
All right, and Richard, I'm going to throw this next one to you. If a sterile cycle passes, how do you know to suspect a leak and increase parts per million of hydrogen peroxide vapor?
Sorry, Lindsay, can you say the question again?
Sure. If a sterile cycle passes, how would you know to suspect a leak and an increase in parts per million of hydrogen peroxide vapor?
I think that's a very difficult one for people to do because hydrogen peroxide has almost no smell. Personally, I've tried smelling 20 ppm. What I know is 20 ppm, and I could smell nothing at all. So, if there's gas coming out, one would never know it. And so that's why it's recommended to have some kind of continuous gas monitor for hydrogen peroxide on top of the sterilizer. Otherwise, there's really no way to know if it's leaking or not. And most of the cases it won't be leaking. It's like a smoke detector in the house. I have smoke detectors in my house, as we all do. I don't expect my house to burn down, but if it does catch fire, I'm glad there's a smoke detector there.
All right. Are there, and Richard, I'm going to send this one over to you as well. Are there any studies showing the long-term negative impacts of chronic exposure to vaporized hydrogen peroxide?
Yes, there have been a number of studies. The earliest ones were studies with dogs back in the 1950s. And those studies showed that even fairly low concentrations, low ppm concentrations over a prolonged period could cause damage to the lungs. But there have been a number of studies over the years since then.
All right, thank you. And Matt, I'm going to throw another one your way. Are there any studies, actually, sorry about that, there must be another way to process equipment, is this comment. Can you address this?
Well, yeah, I think we come across a lot of people that say, well, there must be another way to do it. Unfortunately, you know, there are other methods with steam or UV light to sterilize equipment, but these specific equipment that's being reprocessed, you know, it's going to need some sort of chemical sterilant, right? So at the end of the day, they're all biocides that are meant to kill all life. Otherwise, this equipment that's going into people's bodies or being used in surgery could possibly give these people an infection, right, or cause death that way. So unfortunately, there really isn't another method. You're going to use some sort of biocide. You know, ETO was used for a long time before people realized how dangerous it was. So you start to get away from ETO a little bit in some cases, but you basically just replace it with another biocide. So unfortunately, there's not really a better way at this time to reprocess this medical equipment. But again, as people have written in, and as you guys have stated, the best thing you can do is be educated and do it as safely as possible, right? And have the best work practices in place. Make sure that you're protecting workers and still reprocessing the equipment to the best possible way.
And Matt, as a follow-up to that, can you just give a brief description about the difference between ethylene oxide and hydrogen peroxide? You had mentioned that you replaced one dangerous chemical with another. What is the main difference between those two chemicals?
I'll actually push that one to Dr. Warburton. He's an expert on both of those chemicals.
Okay. I'm not sure about the expert part, but yeah, ethylene oxide has been used for sterilization for probably since back in the 1920s to 1950s, and it is still today the most common method for medical device manufacture. Whereas in hospitals, hydrogen peroxide is the most common chemical sterilant method. They're both very, very effective sterilants, i.e. they will kill everything. Ethylene oxide is an alkylating agent, so it tends to denature it tends to react with the DNA and kill that way. Whereas hydrogen peroxide tends to be more it oxidizes the cell membranes and other cell components and sterilizes that way. From a safety perspective, they both have the same OSHA permissible exposure limit of 1 ppm over an 8-hour time-weighted average. Ethylene oxide has an OSHA short-term exposure limit, excursion limit of 5 ppm. Hydrogen peroxide does not have an OSHA PEL, but a couple of states have, Hawaii and Washington have short-term exposure limits of 3 ppm. So from a occupational exposure limit, they're fairly similar. There's also an IDLH, the immediately dangerous to life and health limits, which for ethylene oxide is 800 ppm, and for hydrogen peroxide is 75 ppm. So the IDLH is the concentration at which the chemical causes long-term harm, or it affects the person so much they're unable to escape from an area within 30 minutes. So.
Great. Thank you for that. And along those lines, Richard, can you describe briefly the difference between hydrogen peroxide vapor and plasma for an audience member, and probably multiple, if you don't mind?
Yeah, there are several hydrogen peroxide sterilizers out there. There's the V-Pro from Steris, which uses hydrogen peroxide vapor, and then there's the Sterilite line from ASP. And in both cases, the sterilant gas is the hydrogen peroxide. ASP also have a plasma cycle or a plasma stage at the end of their cycle, and the plasma is a fully ionized gas, and its role in there is to remove the residual hydrogen peroxide at the end of the cycle. And there might be some additional sterilization capable from it, but its primary role is to remove the residual hydrogen peroxide at the end of the cycle. And it's induced by applying a radio frequency inside the chamber.
All right, great. We do have time for one more question. And Matt, I'm going to throw this one over to you. It says units are allowed to forego needing continuous monitoring regulation if they can show that they release less than a certain parts per million when the door opens. This seems to provide a false sense of security, as I've had manufacturers and management refer to this when requesting a monitor. How do we combat that, and is there a need for more stringent regulatory guidance?
Yeah, I mean, me personally, the goal, it's kind of a catch-22. I mean, obviously, the goal is to have monitors in place to understand your environment and to make sure of no big leaks, right? But at the end of the day, you really do want those monitors to read 0.0. I don't know about everybody listening, but me personally, being around it or the people I'm working with, I don't feel comfortable saying that as long as it's under a regulation. I mean, yes, that's the goal, to keep it under a regulated exposure level, but me personally, I'd like to see it as close to 0 as possible. So to say that you should be able to be around something that's a toxic chemical a little bit, and you should be able to just deal with that, that doesn't settle well with me. So I really think that, yeah, there should be more regulation around it, and really no leakage should be the goal. So I think it really just comes from sterilization techs and managers reporting issues. I mean, I've seen several people on here too talk about there's, reporting, and I just think there's a lot of things that happen because there's not education, that people don't even know to report what's going on or what they're feeling. So I think it's really about education and letting people know that they don't want to work in an environment that could be toxic to them and harmful to their health.
And if I could jump in real quick as well, this morning I was reading an article coming out of Massachusetts where they've been decontaminating the N95 masks. And nurses now are reporting quite a bit of physical health issues related to trying to wear those masks. Dizziness, feeling like they're going to pass out, a foul odor. So if they're experiencing after they've been decontaminated, I can only imagine, again, the level that these sterilants are at while they're in our department when we open the door, when we have the machine in use.
All right, thank you. And that is all the time that we have for today. Thank you to Dr. Warburton, to Bob, and also to Matt for the answers to the questions that came through. We didn't get to all of them, but we will address your additional questions one-on-one via email. Thank you for tuning in, and we'll see you in about 15 minutes for Dr. Peter Nichols' talk on the need for interdisciplinary innovation. Thanks, everybody.